So thank you, everyone that's joined us. A really, really warm welcome. This is the second in the series of webinars that we are doing. The first one was on pathophysiology, and today it's on assessing and diagnosing long COVID. We're really lucky to have Uzma, who's an excellent speaker, and she's worked really hard on these slides. And she is going to put the primary care touch to it, but we're also very lucky to have Adam, who actually is the lead, long COVID lead. Lots and lots of questions, hopefully, that would be coming both the presenters' way at the end of it. Just a bit of housekeeping. So if you could just turn your cameras off, really helps. The presenter certainly helps me when I'm presenting to focus on the slides. We will have 20 minutes of presentation each, about 40 minutes, and then questions at the end. But please feel free to put the questions, because if there are a lot of them, then I might have to just look at the themes that are coming through. Otherwise, we will ask you to put the questions forward. The webinar is being recorded, and it is going to be saved on the Training Hub website, who are the hosts really of and the sponsors of these webinars. And CDART has kindly, or is going to kindly, put the website address on there. We also would have a feedback on the function that please do let us know, so we can constantly monitor and change the way we deliver these webinars for the future, which are lined up, I think, is all on that Training Hub website. So without further ado, I can just please remind people to go off the camera. Can see one person. Emma, would you mind just turning off the camera there? Thank you. And I will hand it over to Uzma to take us through. Thank you.
Hi, everybody. I'm Uzma. I'm a GP in Barking Dagenham at Gable Surgery. I also work for the BHR CCGs, which is in the BHR ICP in the NEL ICS. And I've been working on COVID and long COVID along with our secondary care colleagues in the CCG. Can I please have the next slide? Please, thank you. So I thought maybe if I put some aims, like what I intend to cover in the presentation, and some objectives, or what you'll be able to do by the end of the session. So so I'm going to talk about what is long COVID, and sorry, I'm not going to try and be patronizing or anything, but just nice to cover some common grounds there. What are the symptoms, what investigations we can do in primary care, and when can we refer them? So by the end of the session, you'll be able to diagnose, investigate, help your patients, and then, you know, refer them on at the right stage and to the right specialty. Please, can I have the next slide? Thank you. So with long COVID, it has a COVID infection, you know, it has different phases. You'll see people using different terms like acute COVID, ongoing symptomatic COVID, post-COVID syndrome. And I've noticed the post-COVID syndrome and long COVID is used interchangeably. So the acute phase is less than 4 weeks. And then between 4 and 12, you can code them as ongoing symptomatic COVID. I would really request everybody to help code these things on emails, because it helps pick up any data to see how prevalent these symptoms are. And then you do have a code for post-COVID-19 syndrome, and most of these symptoms would have developed during the infective period, but if they persist after 12 weeks, then we're considering calling them post-COVID syndrome. And the important thing is to bear in mind that these are symptoms that are not explained by an alternative diagnosis. And and most of the time in the trajectory of the illness, life-threatening complications can occur, and they will need investigating urgently. So obviously we wouldn't wait till 12 weeks to investigate. Please, can I have the next slide? So I think it's worth mentioning what is being observed. So there's been various studies being published in the BMJ and the British Journal of GP, the Lancet, and there's a huge variability in the percentage of symptoms people are reporting. So there is something like 15 to, I mean, it's a huge variability, like 16% to 56% reporting symptoms after 12 weeks. after 12 weeks. And so you can see that I've put a chart there, which is from one of the BBC websites. And it just shows that fatigue and shortness of breath seems to be the most reported symptoms. A study in China showed that actually in hospitalized patients, shortness of breath and anxiety had increased in the months between sort of 6 months to 12 months after discharge. And the positive was that 88% of people who were employed before they caught the infection were actually back to work at 12 months. And the likelihood of developing long COVID doesn't seem to be associated with any particular symptom that they develop in the acute phase, or the severity of the infection, or whether or not they were hospitalized. We still don't have much data about the incidence of long COVID in people who've been vaccinated. Can I have the next slide, please? I think the most important thing is when patients first come out with the infection is there's a lot of curiosity. We don't know much about this infection. It's quite a new thing for all of us, and patients get very anxious. So I think it's worth sharing with the patients the normal trajectory of what would they expect to recover, how long will it take. Written info is better because what we're noticing is that due to the fatigue and cognitive symptoms, there is a reduced ability to take in complex information. And this seems quite obvious, but I think it gets overlooked. Self-monitoring can be beneficial, and we've had the pulse oximetry schemes running locally, but it does have a potential to cause anxiety, so you might want to choose your patients carefully with that. There is this website which is recommended by the NHS, and it's really good. You can send them this link in the Accurix, on text messaging, whatever service you use. And these are the codes I thought might be worth putting in for the GPs in the group. So you can say that you've signposted them to the COVID recovery website. Can I have the next slide, please? So I came across a document by NHS England, which was talking about how to assess and manage long COVID in primary care. And I thought this picture was quite helpful in me trying to understand what I'm trying to put across to you. So you can see there's a majority of people will need triaging and screening if they've contacted primary care, but very few of them would actually need any assessment or treatment. And then you can see there's even less people going. So there's 3 tiers. You can divide them into like the green color, the pink, and the sort of browny orange color. So majority of them will be able to self-manage, and so you can see the main symptoms like mental health, palpitation, chest pains will be able to self-manage, majority of them. Very few of them will need primary care or community service referrals, like for neuropathy, fatigue, or mental health issues, breathlessness. Then there will still be a few people like who will end up being, you might need to refer them for specialist or rehab clinics, like for fatigue, breathlessness, palpitation, chest pains. There will be still some that will trickle through, but the majority of them will be able to self-manage or manage in the community. Can I have the next slide, please? I thought it's worth mentioning that long COVID is a multi-system disorder, as most of us would have encountered. And so I thought I'll put a list up here and with all the different organs and what you can actually see. So there could be general non-specific symptoms like tiredness, fever, pain. They'll be absent from work. There'll be reduced performance at work. And these are really, really important points. And it makes a big difference to the patient that their clinician listens to them and has a good empathic consulting style in this phase, because what we're noticing that there is no particular intervention that has been shown to be effective, but definitely we've seen that empathic consulting styles has made a big difference to their mental health, fatigue. They can have persistent respiratory symptoms, and a lot of people have noticed what we've noticed in a lot of cases is the thromboembolic event, and the hospitalized patients get anticoag, but we don't know the incidence of this in the community because majority of them are self-managing and they don't need any help. Can I have the next slide, please? So this is the rest of the systems I thought worth mentioning: the neurological signs, the brain fog, cognitive impairment, loss of concentration, a lot of other neurological complications like ischemic stroke, seizures, encephalitis, and cranial nerve neuropathies have also been observed. NICE seems to mention some other symptoms with no specific management, like for joint and muscle pain, abdominal pain, nausea, vomiting, weight loss. In ENT, there's tinnitus, earache, sore throat, loss of taste and smell, nasal congestion, skin and hair loss, mobility impairment. And the BMG highlights the risk of pancreatic, liver, and AKI injury and renal impairment. And I think a lot of us are noticing that a lot of patients are coming out with AKI, stage 1 injury and renal impairment. And we just don't know what else to do apart from monitoring it. And NICE certainly doesn't have any specific management for these patients. Can I have the next slide, please? And there are still some special cases, because we know no one is immune from it. So there's children being affected as well as older adults. So children, we're noticing that there will be poor concentration, short-term memory loss, difficulty with usual tasks, and this will be ongoing for more than 4 weeks. They're less likely to have shortness of breath or cough or pain, palpitations or chest pain. Older adults, we're noticing a lot of muscle loss and reduced appetite. So it's all contributing to their frailty getting worse and their dementia getting worse. They report a lot of reports of delirium, and they're requiring a lot of short-term packages, advanced care planning. They're getting very isolated and lonely in all of this. So it's just knowing the local services and incorporating social prescribers and care coordinators within your PCN for this has been shown to help. Can I please have the next slide? So we are going to touch upon the assessment and management of long COVID further on, later on, from a specialist point of view. But I thought it would be worth mentioning here from a primary care physician's point of view, what I can do and we can do in the community to help support these patients a bit better. So symptoms which have been there for more than 4 weeks after the acute phase, after the acute infection, should be reviewed in primary care. I mean, it goes without saying, we will do a clinical history, nature, severity, and just to be aware that the symptoms are fluctuating, and the impact on personal and social life is very, very important to discuss here, and makes the patient feel heard. So we have a few screening questionnaires that have been recommended by NICE. They're not validated tools, but they have been recommended by NICE, and they can be used as an adjunct to our consultations. So the one that's mentioned is a Yorkshire rehab questionnaire. It's developed in Leeds, and I've put a picture of it. It's like an app, and it tracks a patient's symptoms progression as the months are going on. You can see the circles, and it's very good. I think patients do find it helpful, and they enjoy kind of monitoring their symptoms and see how some are developing, some are progressing, some are regressing, and they're getting better. There's also a pediatric follow-up questionnaire that can be used, which is also I've put the link in this presentation for you. Next slide, please. And obviously this investigation management will be covered on later, but I think it's from a primary care physician's point of view, it's worth mentioning that long COVID is a diagnosis of exclusion. So there is a lot of other things that we'll have to think about before we get to the point that it's long COVID. We can look at their pre-morbid state. What are the comorbidities they suffered with? Have they actually got worse with this? We think about other conditions, and we investigate any red flags as we always do, and for ongoing symptoms after 4 weeks, we can start doing some bloods, BMP for heart failure, ferritin, and BMJ seems to mention troponin, but I was still of the opinion, if it's troponin, I think probably needs an admission rather than us doing it in general practice as a regular test. And D-dimers as well. If it's negative, that's really good, but if it's positive, it creates a lot of medical uncertainty. And then postural symptoms, palpitations, dizziness. We can do a few things. NICE seems to mention this 3-minute active stand test, and it can be extended to 10 minutes if we're suspecting POTS. So it just says to lie a patient down, check their blood pressure, heart rate, and then recheck when they stand. And you keep doing this at 3-minute intervals for up to 10 minutes. Can I have the next slide, please? So management of certain features, which I just wanted to touch upon from a GP point of view, like fatigue and general non-specific symptoms. So with fatigue, there doesn't, it's very common, and the rates seem to differ in the studies quite a lot, between 12% to 93%. There's no evidence for any drug or non-drug interventions, and there's conflicting opinion about CBT or psychological input. There's a very good study, there's a very good paper in the BMJ for the reference there. So again, they do ask us to do the 1-minute sit to stand test with breathlessness, pulse, and SATs being measured. So the main, I'll put a picture up there just to remind us. The main thing, it says stop trying to push to your limits, rest as much as they can, and pace their activities. In general, non-specific symptoms that people are experiencing, like tiredness and work-related, so holistic empathic assessments, I think we should recognize and value the rapport and the relationship we have as GPs with our patients. They do listen to us, and they do value our time with them. And just having that, I've noticed Doctor as a Drug has really helped most of my patients through this journey. And most of people will notice significant improvement at 6 weeks with exercise and yoga. But the goal setting and general well-being is the bit that we need to focus on. And with work, the Faculty of Occupational Medicine has a really good guidance. I put the link there in my presentation for people if they would like to read it and see how they can help with phased return and amended duties. No particular vitamins have been recommended, so I wouldn't really recommend vitamins. Vitamin D especially is not recommended to prevent or treat COVID-19 infection. Can I have the next slide, please? Yes, and there's obviously thromboembolism and mental health that is very is also affecting them. The main thing with mental health is it affects about 34% in the 6 months after the infection. A lot of healthcare workers are experiencing PTSD, and it's just recognizing that in them, which really helps. I think we should refer them immediately if there's any suicide or severe psychiatry symptoms. Sorry, there's a typing error there. And yeah, and urgently, and there is mental health provision for this. Thank you. Can I have the next slide, please? So I think Adam's going to touch upon the respiratory symptoms. There's a lot we can do. Most of it gets better in the first 6 weeks. But if there is something, basic things we can advise them as GPs is to stop smoking, avoid pollutants. I don't know if they can manage that in London, and avoid extremes of temperature. Can I have the next slide, please? Yes, so cardiac and neurological symptoms as well. There are quite a few things that, we can look out for. So if chest pain, I mean, I would admit if I'm expecting ACS, and ECGs are helpful. People coming out of hospital who've had myocarditis should avoid intense exercise for at least 3 months. And this was something I wanted to mention because this was something I didn't know. And, patients might ask us for advice, or what do I do? And athletes, high-level athletes, will need specialist assessment before returning to sports. Can I have the next slide, please? So I think as a summary, points to consider with long COVID is that it is a sequelae of COVID-19. It's a multi-system disorder, fluctuates and lasts for prolonged periods. And you don't need a positive test to diagnose long COVID. So it can be considered in anybody with suspected or confirmed COVID infection. It's a new entity, so we don't know much about it. There's very limited evidence for any intervention, but that's not to say that these interventions are not going to work or it's not worth carrying them out. An empathic consulting style seems to be the best. I mean, I usually share my frustration about the uncertainty with my patients, and then we find a common ground there to work with. I do ensure that their management of comorbidities is optimized, especially diabetes, high blood pressure, or their mental health like anxiety. It is a diagnosis of exclusion, so we don't want to miss any other conditions. And I think with this, I do want to thank Jyoti for letting me loose here, and I'd like to thank Adam and his team for supporting us throughout the pandemic. He's been a rock, and I'm not just saying this for nothing. I will be sending my bill later. So I think with this, I would like to hand over to Dr. Ainley, who's going to do the rest of the presentation.
Thanks, Uzma. Adam, I'm going to hand over to you. You're on mute.
Thank you. Thanks, Uzma. Thank you for starting the talk so well and eloquently. I'll try and continue in the same vein. So I'm Adam Ainley. I'm one of the respiratory consultants at BHIUT, and I run the long COVID service, and I'm the acute respiratory COVID lead also for my sins. So I'm just going to give you a bit of an upshot potentially of what we do once you've referred to the long COVID clinic. So as Uzma so eloquently put already, it is a diagnosis of exclusion. Essentially, at this current point in time, we have no clear diagnostic test to pinpoint the diagnosis and certainty. And very much a lot of this is about a very much holistic approach to assessing your patients and being as broad and as general as possible to make sure that we don't miss anything. So once you've got our clinic, essentially, I'm very fortunate in that we have a number of different supported elements within it. So I have myself, I have one of our or two of our registrars sort of undertake the medical assessment. And then within our clinic, we've also got an occupational therapist, some physiotherapist. And we did have at one point the clinical psychologist sitting in with us, but because of the length of their assessments, they now do a separate stream to assess the patients. And the whole concept of the clinic is essentially to try and do a formal, thorough assessment of all aspects of a patient's symptoms, to try and elicit what the actual issues are and how we can best support them. So next slide, please. So as Uzma's already described quite clearly, long COVID is a multi-system syndrome, and it affects people in such a myriad of ways that it can really much mimic a multitude of other conditions. And that really is the challenge here, in that what we've got to try and do is make sure that there is nothing else that's caused their symptoms. I very much in the beginning of our clinic saw a number of patients who in fact had progressive heart failure, which gave them breathlessness, fatigue, myalgia, tiredness. We were seeing people who'd had heart attacks, who sort of late presentations because of COVID, but had breathlessness, characteristic ECG changes, angiograms showing they'd had missed MIs, all of which gave them the same symptoms. And we also know that it very much is associated with exacerbations of pre-existing conditions. So we know there's an association with pre-exacerbation of ischemic heart disease. We know it has brought out those people who are asthmatic or stably controlled or mildly symptomatic and therefore hadn't presented at that point in time with asthma. We know it gives people a post-viral cough. Equally, there's very much an association that's being currently explored, and the evidence is coming out showing you that it may drive inflammatory processes and either drive forward autoimmune conditions or be part of the actual presentation, so have exacerbated them or actually triggered them. So it's very much trying to make sure that we don't miss anything that is we don't miss anything that is actually there but is an alternate condition, so that we make sure people have timely treatment as soon as possible. So for all of these reasons, we will review again once people have come to the clinic, just to see what has been done so far at the point of referral, just to make sure that there's been a really thorough tooth comb going through all of the things that could be excluded. Next slide, please. So I think one of the key things when assessing anyone who's got a potential post-COVID long COVID syndrome is actually trying to work out how they've been affected. And I think something that's really come out in the feedback from our service is that the public, there's lots of debate about long COVID, about how it affects people, who is affected, how many people are affected and why. And actually something that's really important is that these patients are valid in what they're experiencing, and whether or not we have a gold standard test which proves they have this syndrome, they are experiencing the syndrome, and it is very much a thing. And it's really important to validate that when they come. As I've said, there's no clear diagnostic test that will tell you this is long COVID, like we have for heart attacks in some respect, like we have for some cancers. We don't have a long COVID test to say you've got long COVID, which also makes it more difficult when you're trying to assess patients, but also to give them a result. Equally, many of our patients had COVID at the very beginning of the pandemic, so didn't have a COVID test, or equally a negative on antibody tests. So again, how do you prove they've actually had COVID? So it is quite difficult in some aspects. The vast majority, thankfully, because we then did start testing, had a PCR at some point confirming they actually had COVID, and the vast majority will be antibody positive, slightly more difficult now with vaccination status, but they will also be antibody positive, which does give some weight to them having had COVID first, which is helpful for them. And secondly, then we can then explore everything that's happened since then with a timeline. As I've said, it's all about taking a very broad general assessment. It's about taking the history. It's about working out when they think they had COVID, or if it was confirmed, when it was confirmed to have happened, and then really going through the timeline of the story, because actually it's a story that's very interesting, because they generally will have a cluster of symptoms that have happened over that time. We see very few patients who've got one or two symptoms. That normally rings alarm bells to me. If you've got one symptom, so you just have chest pain, my threshold to say you've got long COVID is much higher, because most people will have breathlessness, fatigue, chest pain, all of the symptoms, or at least a few of them. Very few just have one. Again, very few just present with breathlessness at all. They will have had some other symptoms on the way, either that have happened and are now got better and gone away, or they're still there. But very few just have one symptom when they present. And it's really important, not for us as clinicians, we all generally try and focus on the physical, but actually what is their emotional well-being, what is their mental well-being, and actually how has this affected them in terms of their life, looking after children, in terms of house activities, about activities of daily living, financially, how has this affected them, because that all affects how they feel physically, and it's so important to do a really holistic assessment. Next slide, please. So what are we seeing? You know, the literature is now getting bigger and bigger and bigger, and we're getting a lot more data about what people are experiencing. I mean, when I first started in the clinic in July 2020, we had, you know, I was asking people, had they ever seen hair loss in this cohort? But we now realise that at least 8% of people with post-COVID syndrome will have experienced some form of hair loss. So we're very much learning along the way. And I think, as Uzma's already mentioned, it's really actually powerful to be in some way open with patients and transparent about the data still unfolding, that we don't know all the answers yet, and actually hopefully with time we will do. But what we can say is that we haven't found anything necessarily worrying in tests that we do. There's no red flags, so this is something else, because a lot of them are very worried about having underlying malignancies or other conditions. It's about trying to be as reassuring but as safe as possible in that message. So as I said, we see lots of people with breathing pattern disorders, exacerbations of pre-existing disease, myocarditis and palpitations are very much things that people do see after COVID, and it's about trying to see how much that's affected them. POTS is certainly something that's coming out in the literature as being quite commonly associated after COVID, so it's assessing them for tachycardia and postural changes. And as I said, it is bringing forward existing conditions which were potentially either there quietly or have been driven now by their COVID inflammatory episode. And as we learn more about the pathogenesis of long COVID, which we're currently doing, it's thought to be driven by an inflammatory process. So is this something that was always there that's been brought forward, or is it a secondary inflammatory response to the acute onset of COVID? That we still don't have great certainty on, but I'm sure we will over the next sort of 5 to 10 years. Again, we've seen people with menstrual cycles, we've seen people with dysfunction in their thyroid as a subsequence of their infection. And is that actually long COVID, or is it that this is a side effect and a complication of COVID? There's still much a sort of grey zone about how you define these things. And then, as I said, because of the physical nature of their symptoms and their syndromes, that can have downstream emotional and psychological difficulties. Next slide, please. So what we do in the clinic is, once we've really gone through everything again to make sure nothing is there that could pinpoint to an alternative diagnosis, because this is one, as I said, of exclusion, it's about trying to ascertain how much that patient is affected by it and what we can do. And there are a number of validated tools that are now coming out to support that. So the Yorkshire screening tool is something that Uzma's already spoken to. that came out from the north of England to really go through the symptoms that people are known to present with from COVID and how it affects them. So it very much scales things on a score of 1 to 10, and you can gauge just how severely they're affected. And we can use these as monitoring tools also to assess response to treatment and intervention. The Newcastle screening tool and the post-COVID functional scale are equally similar tools that look at a range of different symptoms and function and how it affects people physically. Then the GAD2, PHQ and TSQ are probably things you're probably more familiar with because they're already pre-existing screening tools for anxiety, depression and trauma. So has someone got these features as a subsequence of their illness? And then there are newer tools, well, not newer, but they're existing tools that we also now use to look at different symptoms. So we use the BPAT score, which is a breathlessness tool, to assess how much their breathlessness is affecting them and how severe it is. We will do things like breath hold to look at if there's any evidence of a breathing pattern disorder. And we've developed locally within our service a breathing pattern score, which will tell you how affected they are. And the literature will give you a number of different scores to use, but the breathlessness score, BPAT, are things that are commonly recommended and are used around most services in London and the country. And then the MRC score is something you're probably familiar with, is a score used to try and grade how affected you are by your breathlessness. And this is already pre-existing and used in a number of respiratory conditions. In terms of fatigue, so the FACIT or the FAS score are two most commonly used fatigue scores, and this will look at a number of different things, looking at how you're affected by fatigue and what things precipitate or exacerbate your fatigue. And then depending upon the score, you can say you've got fatigue or not. And then that sort of guides as a starting point as part of the initial assessment. Again, mental health screens, as I've already spoken to. And then something we're also trying to incorporate much more now is how your life is affected by your symptoms. So the EQ5DL with a visual analog score and the WASA are two other scoring systems to really see how your symptoms are affecting your ability to work, ability to function in society, and therefore what effect your symptoms may be having upon your quality of life, and then how we really can support you in all aspects. So we'll look at these tools very much at the very beginning as an initial screening tool, and then we're trying to use them as monitoring tools also to see how we can monitor interventions to try and give us an idea of outcome. Next slide, please. So obviously after assessment, you then need to try and work out, what is going on. And we very much recognise there are known complications of COVID. Again, are these actually part of a post-COVID syndrome or are these complications? It's still a bit of a grey zone, and some could argue either way that actually some of these are complications and not actually part of the syndrome, but we still undertake the assessments anyway regardless. So we try and look at, once you've listed the symptoms, try and hone in really if there's a cause which we can either manage medically or at least try and give them an answer. And actually, interesting, a vast majority of these tests will be negative. And even if they're negative, I think what a lot of patients experience very early on, or they've got from things reading in the media, is that, they get told very commonly a test is negative. You're fine, don't worry, go away, your symptoms will get better. Just because a test is negative does not mean they are not breathless or that they are not fatigued, because not all of our tests are yet, sensitive enough to pick up some stuff which we may later find is possible. I mean, the image at the top of this screen shows a Xenon MRI scan, which is being explored in Oxford as a tool to look for vascular abnormalities, so things like microclots. That work's still being done, but in 10 years, this might be something that we're all doing. We don't know, but we're not yet, and it's still just a research tool. There are lots of things like apophoresis, which are being done in a study in Germany, which is essentially a form of dialysis for clots. Many patients will come and speak to you about that, but actually the data is still very limited. It is in a very small cohort of maybe a few hundred patients, which in the grand scheme of evidence is still very limited. So as I said, what we do is we try and focus our diagnostics, looking at their symptoms to try and give them a reason. So we'll undertake for respiratory, for example, looking for any evidence of a pneumonitis, a worsening of a pre-existing respiratory condition, if they've got a new diagnosis of asthma, or could they have bronchiectasis as a consequence of their COVID pneumonia, because this did very much cause a lot of damage to the lungs in some people, so they might have developed this. And then if not, actually, are we dealing with a dysfunctional breathlessness disorder? So we'll do things like a breath hold, we'll do breathlessness scores, and then actually physically look at them and see if they look like they've got dysfunctional breathlessness. Cardiovascularly wise, we'll be doing things to exclude cardiovascular complications. So could they possibly have a myocarditis? So often starting with an ECG. We in our setting are fortunate enough that we can get the results quite timely. So we will utilise things like a troponin here, because is there some kind of myocardial injury or damage? And again, we will look at if there is a cause of ischemic injury that's been missed. And we'll also do things like a 24-hour tape if they've got palpitations. So we're looking here for the degree of palpitations across 24 hours, and is this how it's affecting them? And again, we'll try and ascertain if we can control that. In terms of fatigue, we're trying to exclude all the things we commonly know. So maybe we've seen many people who've got B12 deficiencies. Actually quite interesting. Is that cause or association? We're still very unclear, but quite a lot of our patients are iron deficient, they're B12 deficient. Some of them have been low in thyroid, so they're hypothyroid. That was the new presentations. Again, we're finding people who, and we've also got to take into account, a lot of people were given steroids during their admissions. I don't think in our history have been given steroids to so many people in one go as we have done in COVID. And we've been using loads of other new medications too. So we've been using a lot more immunosuppressants, although be it for short periods. Lots of new drugs that were given to patients during their acute illness, if they're in hospital, for example. And actually going forward, some of these people will be getting stuff in the community. So lots of people now will be getting antiretrovirals, getting immunotherapy within the community settings, who will never have touched base to secondary care, but would have been given a new drug that we are still going to have to think about later when they present. Again, we're seeing people presenting with irritable bowel type syndromes associated with COVID. So it's making sure that we're not missing any kind of GI upset, any colitis, looking for things like H. pylori here, that we need to exclude also in looking at whether this is actually COVID associated IBS, for example. And again, a lot of patients will present with headache. A lot of this is fatigue driven. This is associated with fatigue. But some of these people will have migraines also. And we also don't want to miss that some of these people will have other conditions. And as part of neurology, we'll also assess for memory impairment. The vast majority of our patients are younger. So we often see the cohorts currently with long COVID are generally females in their 40s to 50s. So not less likely to have dementia, but we still do the initial screens to make sure. And certainly in those who are in the older category, we want to make sure we're not missing a dementia process that's actually unfolding in the background. Next slide, please. So I think the main things are what areas need attention. So we try and work out what the predominant symptoms are. Make sure we've done the test to try and work out how severe these are. Try and work out if there's an underlying exacerbation or a new condition there, and then try and manage that. It's really important to see how it's affected them. So is it affecting their life? Is it affecting their work? Is it affecting childcare? Is it affecting them emotionally and mentally? And then we look and see how we can meet that need. I'm very fortunate because I have, the support of all the investigations around me, and I have a really great team who are really involved and engaged. So once I've got someone who's got breathlessness, I can still give them to our physiotherapist, who'll do some breathing pattern work with them, try and get them more mobile, get them walking. We've got to remember that in the last year or two, a lot of people will have been sitting at home much more sedate than they were before. So the vast majority of these people are deconditioned. They've lost a lot of muscular strength by sitting at home and walking. Not working for 9 months due to lockdown or working from home. People really don't acknowledge actually how walking 10,000 steps a day subconsciously just by walking to work, if you don't do that for 6 months, you can be massively deconditioned. So it's about not only having had COVID, it's about the situation in which they got COVID and the impact of the last year of being functionally much less active than we were before, being also bombarded in the daily news by the fact that COVID can kill people, that long COVID may not be treatable. The impact of being bombarded with that daily is something we always try and get our patients to appreciate. And it's also getting them to accept where they were before COVID. Actually, they've got to remember what they were like at the point they got COVID, and we want to get them back to that point, not necessarily where they were before 5 or 6 years ago, because that might be too much in the explanations initially. We've got to really much set expectations in recovery. And then, as I said, how can we support their needs? Next slide, please. So as well as us doing the work, I think it's really important, as with most conditions, we try and empower our patients. So there's a lot that patients can do that is really helpful to help us reassure them. So we do a lot of technology. So we work with the Living with COVID app and Your COVID Recovery. We get patients to fill in symptoms diaries, which we monitor and track their symptoms over the course of their interventions. It's important to recognise the impact of sleep. So getting people to do a good sleep diary, because actually, whilst COVID may affect their sleep, actually they it can be affected by so many things. So we're looking for their sleep pattern. When do they go to bed? What's their sleep hygiene like? This is what we try and elicit. Pacing. Patients will come back and tell us, I'm extremely fatigued, but they've gone back to work full time. They need to take time off. Actually, what is it in their day that makes them fatigued? Is it physical? Is it mental? Is it the work pattern? So we look at these tools very much to try and help these patients to work out what fatigues them, what exacerbates it, what precipitates it, and then how we can try and mitigate those things. Smell and taste. Stephanie will talk about management probably in the next series talk, but again, getting a concept of what is it in their taste or smell that's altered, and then we can try and elicit how we can manage that. And then breath hold, looking at how long they can hold their breath for is certainly important, because if you can hold your breath for less than 30 seconds, that is suggestive potentially of a breathing pattern disorder, as well as other things, obviously. But if you've excluded other respiratory complications, it may very well be a breathing pattern disorder, so a dysfunctional dysregulation of your diaphragm with the rest of your respiratory muscular work. That can make you feel breathless because you're not really using your muscles properly or inflating your lungs as much as possible to get the air where it should be. So you will breath stack, you will take very, very small, shallow breaths, but you won't take a full breath. So you will be breathless because you're not utilizing your lungs as much as possible. And then fatigue. This is again talking about pacing. How fatigued are you and when are you fatigued? And we use a number of different apps and things to guide and support people with this, as well as paper charts for those who are less technologically apt. Next slide, please. So once we've done the initial assessments, we often reassess. So we'll review in clinic. In terms of therapy, we have a 6-week virtual program now. We run all of our patients through, running through things like breathlessness, fatigue, mental health, work, other symptoms that may come out, and a general overview of COVID. And then at the end of that 6-week program, we do an initial assessment, a mid-assessment, and then we do a run around 2 weeks after that program's finished. And then we'll also do face-to-face assessments based upon the assessments that come from that virtual program, if people still have a need for more support above self-management, or we do home and site-based assessments with them also. And a lot of the medical and therapy reassessments overlap in some way, because we're all looking at the same things about how they're affected by the physical and how that affects the mental health and well-being, and also what's happening with work. Have they gone back to work? Are they financially secure? So it's very much an initial and then a reassessment until we think things are going the right way. Next, please. And then I think this is some of our feedback so far. What we can't neglect is that a lot of these patients just want to be heard. They want to get some validation that what they're experiencing is real. And actually, for a lot of them, it is real for all of them. But it is very much something that we can't prove 100% because there is no tests, I've said. And for many of the investigations will all come back normal. But that doesn't mean they don't have a syndrome. It doesn't mean they're not unwell, because a lot of things like breathing pattern disorders, post-exertional malaise and post-viral fatigue, you cannot prove because there is no test. It is about really much listening to the symptom, getting the pattern recognition of what is their symptoms, and then managing that. And actually, that's where the value really much of our service is. Next slide, please. So as I've said, the research is very much unfolding, and we are learning more and more every day, and us being open with our patients is really important. We learn from them very much as they learn from us, so we've really got to work together to try and get them the support that they need. Next slide, please. And then there's some really fantastic resources. So obviously this is a link to how you got here, to the Newham Training Hub, for example. Your COVID Recovery is a national platform, and actually the value much of these platforms is at the very beginning they were very much in one language. They're now being rolled out in multiple languages and much more accessible. So actually, having started working them thinking they weren't as good as we hoped, they're now much better than they were before, and are really good resources not only for us as practitioners but also for patients. Sleep Station is fantastic for sleep management. And then talking about patients and learning from them, the long COVID support is run by patients with long COVID. And I follow them on Twitter and I look at the website. It's great to learn what they're experiencing. They may come along with things that they are finding helpful that we can learn from and then take forward. So I very much encourage looking at some of these really good resources. Next slide, please. So thank you very much. It was just a quick snapshot about assessment. Steph's going to talk more on management next week, which will probably be even more, well, be definitely more exciting than our talk. But thank you very much for inviting me to speak.
Thank you, Adam and Uzma. Absolutely fantastic. I've certainly learned loads today. I'm going to take some questions here, and I have some questions posted in the chat function. The first question, Sarah, you asked about dysfunctional breathlessness. I think Adam mentioned that as well, and I've put the definition. If are you clear on that, or you would like us to explain that again? Because it's really important people understand these definitions. So they can actually explain to the patients or get the right history from the patient. Okay.
Yeah, thank you.
Yep, thank you very much. Adam, Maria is asking about the COVID vaccine, whether patients complaining of long COVID symptoms as a consequence of the COVID vaccine, is there any evidence?
That's a really, really hard one. I think anecdotally, we probably see that does happen. I think there's still literature being sort of written about that. We certainly know it does exacerbate. So many of our patients who've had COVID have had secondary COVID again, or have had the COVID vaccine, and some have certainly found it's affected them and put them back. So I think there's certainly a cohort, but I really would value the evidence seeing in more detail. I think also I still encourage all of our patients to have it though, because actually my argument for that is this is how you affected the first time you got it. Do you want to get it the same way again? Most of us who've got it and it's put them back very slightly, they normally recover again with support. But I don't want to put anyone back to the starting point again. That's normally my rationale for that.
Thanks, Adam. I'm going to move on to the next question, which is about post-viral fatigue. What qualifies for post-viral fatigue for COVID? Would a referral be accepted for long COVID for post-viral fatigue if the patient scores high on the score?
Yeah, we completely accept those referrals because fatigue is really debilitating. So if you are struggling with fatigue, there's a lot that you can be done. I think a lot of it here is about excluding the alternatives, which is what Uzma's already spoken to a lot about today, as have I. But actually, there's a lot that can be done. It's a very difficult thing to manage because a lot of it is about taking time to first explore what makes you tired and fatigued, and then trying to step back from that, which in our very busy lives is almost impossible, because how do you take, I know patients or colleagues who've had to take months off work because you just can't work. You need to relax, but actually, if you can't afford to do that, you can't afford to do that. So it's very much us working together with it, and it's not something you can solve quickly. Yeah, but we do accept those.
Thanks, Adam. We've got a question from Gurjit. Gurjit, I don't know whether you heard, and I've responded about the factors and hormonal changes you've asked due to COVID. Gurjit, are you there?
Yes, Dr. Sood, I did. It's been only because I just wanted some advice, or how can I reassure patients that there isn't anything that we can actually do about it. These are hormonal changes. Yes, it may be related to COVID or not. So I just wanted to know, is there any data or any research to show this, or not? Not really.
So when you talk about hormonal changes, are you mentioning patients presenting with menstrual disorders and thyroid?
Yes, definitely the disorders, menstrual disorders, yes.
Okay. Uzma, Adam, anything? I mean, Gurjit, again, you'd have to rule other things out before you say it's related to COVID, is my sense, but I'd let the experts here, Uzma and Adam.
No, I agree with you, Jyoti. We're seeing a lot of low-level abnormal thyroids. I just manage them as I would if they're under 10. I don't always tend to medicate, monitor. Usually, I've seen it settle over the last year, and they settle. So, yeah. And with hormonal as well, lots of ladies are worried about fertility. and it just comes in a lot of heavy periods, light periods, absence of periods. So again, just help them look at their hormonal profile, and they're usually okay with it. Yeah,
Thanks,
it's
Usma.
spectrals.
Adam, did you want to add anything?
No, I think the main thing is, you've already said, just make sure there's nothing else, because we don't want to miss something else. I know there's this fear of over investigating, but actually, with things like that, I think they're really important to make sure there's nothing else firstly. But actually, for the most part, as Isma said, most of this normally settles, I've experienced. So, things like hair loss, sick thyroid, generally just a transient, but they're quite commonly associated with most post-viral illnesses anyway, and sickness. And again, sort of menstrual cycle disturbance, again, we seem just to be mostly a transient thing. And actually, around 6 or 9 months later, this is mostly better for most people in our experience.
Thanks, Adam. That's really helpful. The next point, actually, Adam, probably you would know this a bit better in terms of the inequalities. And Jonathan is questioning why people with long COVID, a different demography, which is younger, whiter females, less poor. And I was just saying that the REACT study is actually showing those inequalities that are coming out, whether it's access or something else. What's your view? And also it mentioned about 2 million people that potentially that may have long COVID. And I don't know if your sense is that you're actually getting through the numbers that you expect in these clinics.
So Usma and I've already been having a talk about this morning already in another meeting. So yeah, very much. I think there's I have two thoughts on that often. Is that one, we see the epi data in who is affected, but there'll be a massive spectrum of how you're affected. So some people will have very mild breathlessness, and many of our patients say, I'm a bit breathless, doctor, but I'm fine, I'm getting on with it. And actually 12 months down the line, they'll probably be better without any intervention. So do they need to go for all these services, or do we need to be chasing them, say you've got long COVID? If they're fine, they may get better. They'll probably seek help. So that's one group. I think there's secondly another group who have no choice. And this because of things like work, socioeconomic factors, childcare. They are just having to get on with it. And we can try and contact them and get them engaged as much as possible. But actually, a lot of these people, because of their lifestyle, just can't at the moment do that, because, they are just getting on with life. And I think also there's something about we know very much certain demographics of people will really seek healthcare. So actually, they're a very loud group of people. Sorry, not loud, that's probably the wrong word. They're a very vocal group of people who will seek healthcare. They will fit a certain demographic. And even if, I find it very interesting, if you look at the long COVID support groups, a lot of the advocate groups, they are driven by exactly the same cohort that we are seeing in the clinic. They're not very much ethnically diverse. They don't seem to be very socially, economically diverse. It's about, so we're doing a lot more work trying to look at this and see how we can make services much more accessible. We're trying to do work so we're starting our clinic doing things at 8 o'clock to do sort of sessions with people before they go to work or before school, try and do it late in the evening. And we have to be mindful that we still work within set times and we've got a limited staff, but we're all trying to make things accessible in terms of financial. We've opened up some of the pre-rehab stuff that was potentially chargeable before is now free, and it isn't currently because it's funded. So there is lots of work being done to address it. I think it's much more complicated than it might come across in paper, though.
Thanks, Adam. That's really helpful. It's a really good question from Sarah, actually. Does having COVID again generally worsen pre-existing long COVID, or is it just random?
I would say, I was in fact just replying to that before I stopped. So I think it's very variable, because my argument would be, what kind of COVID did you get? so some of our patients have had it and been completely fine. Some get it and are put back mostly in their fatigue, actually, rather than anything else. Some are a bit more breathless, but certainly fatigue seems to be exacerbated by having COVID again in the people that are affected, but a lot of them are not affected.
Yeah, so much variability, and it's just almost okay to say yes to anything is possible with this at the moment. And a lot of it, we're seeing it with other viral illnesses. Like I remember pre-pandemic, when somebody's had proper flu or they've been in ITU, they were exactly like this cohort. following up from after their discharge. So, yeah.
Thanks. Thanks there. Nicholas, you making a comment or a question I wasn't clear. Would you like to come and just say, you're talking about the inflammatory systemic inflammation. Nicholas? Okay, I think we've lost Nicholas. I think there's another question about the ENT guidelines to say refer to ENT all patients who have COVID and still have loss of smell at 3 months. And the thing is that they're not doing it at the moment. Is that the agreed local recommendation then?
So that was the national stuff, and it's still a bit grey, but we are looking at what is required. I think for me, if you got someone who is still very much struggling, then yes, I would encourage a referral, because actually, if it's their sole symptom, because actually, you know, there's a lot of greyness about whether it is or isn't a thing. If they've got a multi-system issue, we are more than happy to see those patients in our clinic, because we will then look at them from multi aspects. But I think it's also making sure there are no red flags also. And there are certainly things that can be done in primary care first before you refer. So have they got an evidence of rhinitis? Could a trial of a nasal steroid be helpful? There's some very weak data about losing things like omega-3 oils, making sure someone doesn't have sinusitis. I've certainly got a number of our patients in the clinic who've got certainly a high degree of allergy. So we've tried things like antihistamines and they've worked very effectively for them. So I don't think it's about blankly saying they're not well at 3 months refer. There are certainly things you could do before then if there are no red flags.
Thanks, Adam. Alpa's commenting on an interesting finding. She's saying there's a correlation between low estrogen for a patient with menstrual sort of disorders, which the patient had normal estrogen before, but after the vaccine, demonstrated low estrogen. Is that something you've come across, Adam?
In our honesty vein, no.
Are you measuring estrogen?
Anything is possible. I'm finding at the moment.
No, there was another paper about this in one of the journals for Royal College of Obstetricians, and it said like it's transient that they've noticed so far, but it's still like a beginning. It's so much we don't know about this. And there was another question there about any pediatric long COVID clinic in Waltham Forest.
Yes,
I don't think there is. I'm not aware of it, but
was that pediatric?
Yes.
I think they normally get referred to the paediatricians, and then there's a centralized service they can get referred to, is my understanding of it. But probably need to clarify further with the commissioners to make sure I'm correct.
Yeah. And I'm sure the Havering is long COVID referral is also on ERS, just like Barking, Dagenham and Redbridge.
Yeah, it's the same one to us by ERS, yeah.
And it's the same doctor, Dr. Ainley.
If you get rejected, it's not me being mean, it's because there's something missing.
I'm glad that question didn't come, Adam. I would have posed it to you directly. Can I just say that there is a link right at the beginning of the chat function. If you follow that link, all the local processes, resources, pathways are on there. There are some areas they're still trying to correct and rejig the pathways. So I'm sorry if it's not all there, but it is what we have as an update. I'm going to take the last question before we close, because we are just a minute from closing, is about the detecting COVID-19 antibodies. A lot of patients been requesting those. Is there any indication for doing the antibody testing?
So I wouldn't do it, because it doesn't prove anything. So if you're negative in antibodies, it doesn't mean you don't have them. It depends how good the assay is. You can still be immune to COVID because you've got a T cell response. Also, what antibody you're measuring, because actually, is it spike antibody from the vaccine or is it immunity? It's too messy. I wouldn't do it.
Thanks, Adam. That's really good. So I'm going to stop the questions here now and thank the wonderful speakers here, and thank you for taking all the questions. Thank you for everyone that's attended. We would absolutely love your feedback. Please do attend the follow-on webinars, because it's just a series that will take you through. The next one is management and MDT management, really, of long COVID. So there'll be a really interesting one. Thank you all. Thank you, Adam. Thank you as well. It's been great.
Thank you, Jyoti. Thank you, Adam.
Thank you very much.
Thanks.
Thank you, Jyoti.
Bye.
Thanks.
Great to have you guys.